This is the Common Health Podcast, a product of the CSIS Bipartisan Alliance for Global Health Security. We engage with diverse leaders on the question of how best to navigate this period of exceptional turmoil, reform, and uncertainty in U.S. leadership. We are aided throughout by our able producer, Marla Hiller. I'm delighted today to be joined by Maria van Kerkhove. Maria, thank you so much for joining us today.
Thank you so much for having me. It's a real pleasure.
Let me say a few words about you. Maria is the acting director of the WHO, the World Health Organization, Department of Epidemic and Pandemic Threat Management. She's an infectious disease epidemiologist, and she got into this starting as an undergraduate at Cornell as a student of biology, and then a master's in epidemiology at Stanford, and then a PhD on infectious disease epidemiology at the London School of Hygiene and Tropical Medicine, where your doctoral research was on H5N1 in Cambodia.
That's right.
Which was a pretty fortuitous choice, given what happened in your career later. When COVID struck, you had been serving already as the technical lead on MERS COVID. And when COVID struck, you raced back to Geneva from wherever you were, and you became at the center of all of the thinking around guidance and what's the science telling us, how do we develop the first tests, and you became the spokesperson for WHO through COVID. So you became suddenly you went from a very inside job to a very outside job, very important inside job, but became the voice of WHO in this fraught period. And as I recall from something I saw you speaking to the media, your mom was carefully recording what happened in these many different press appearances.
Everything.
And the lot. So we've got a whole compilation there for you when you get around to writing your memoir from that period. The scope of what you do is quite remarkable. You do WHO guidance on pandemic, epidemic preparedness response, respiratory disease in particular. You look at all of the high threat pathogens, bacterial threats, biorisk, biosafety in laboratories, affordable access and timely access in terms of vaccines, tests, treatments. So quite a scope to your job and quite an important job. And we're thrilled to have you here. Let's start with your own personal story. I've told the basics of this, but there's got to be a deeper story on what drove you along this path to where you are today, sitting here with us, about to go give the commencement speech tomorrow morning at noon at Georgetown School of Health and receive an honorary doctorate in sciences. Congratulations on that.
Thank you so much.
So what brings you to this moment in time? How did you get here?
Well, thank you so much for that really generous introduction. You've outlined a lot of things that I've done, but the first thing I want to say is I've never done anything alone. I work with incredible people, and I want to start off the top with that. At WHO, my own teams, but across the Health Emergencies Program, specifically want to mention Dr. Mike Ryan, the Executive Director of the Health Emergencies Program, the Deputy Director General, Dr. Tedros, our Director General. Working alongside them has been the privilege of a lifetime. But throughout my entire career, I've worked with people. And I think that's one thing, it's one of my many messages tomorrow in the commencement is that you don't do anything alone. And I'm fortunate that getting to where I am, I never, ever, ever plan to be, and thank you very much for not introducing me as the face of COVID. It's probably my least favorite thing people say because it was such a horrible, horrible time for everybody. And I think we're still reeling from that in many ways. But I fell in love with science in high school. One of my favorite teachers. You grew up in
upstate New York?
I grew up in upstate New York. Yeah. And my AP bio teacher, Mr. Goodfriend, who I still meet with whenever I'm up in upstate New York, he just had this amazing way of teaching in an infectious nature, forgive the pun, or pun intended. And I was learning at the time there was an outbreak in Kerkhove, the Ebola outbreak in Kerkhove that I remember reading about. And there were a lot of books that had come out at the time, Virus Hunters and, the Hot Zone. And I was reading these books. I was trying to devour these books. And I was reading them for the story themselves. And of course, it's a dramatic version of what was happening. But I actually read them for the expertise that people had. Many of them were virologists. They were clinicians.
Yes.
And I was looking at how did people get to do that? What was their education? What was their degree? What was their skill? And I learned about epidemiology. It was the first time I learned about epidemiology. I didn't know about WHO at the time. Growing up in upstate New York and with good healthcare, we didn't need to. And the world was very different in 1995. I'm sure we're going to get into where we are now. But I studied hard. And I was an okay student. I'm not the best student, but I loved the field. Like science for me came alive. I hated the lab, loved the field. And during my summers at Cornell University, I was working with a professor working with medicinal plants in Mexico, Venezuela, Costa Rica. And I just fell in love with talking to people. And these medicine men, medicine women knew all the plants around them and what each of them could be used for prevention, but also for treatment. And just that dialogue, that communication, it was so attractive to me. I craved it and I loved the field.
And this was while you were an undergraduate?
This is when I was an undergraduate. Yeah, there were a few summer trips that I took working with a professor, Eloy Rodriguez from Cornell University. And I was so lucky. I think it was the first time I got on a plane. I don't think I was on a plane before. I was trying to figure this out with my parents the other day, but I loved it. And I went to do a master's at Stanford, which I loved living in California. Everyone should live in California at one point in their lives here and that way of life. And then I needed to get a job and pay back some student loans. So I started working for a consultant company in New York called Exponent. And it was mainly engineering type work. But at that job, what I learned was the weight of the evidence. That skill of pulling together every shred of information on a particular topic and then writing, what did we know about this from every discipline, from every type of investigation, observational studies, clinical trials, case control studies, lab studies, to answer a question. What does this mean? What does this mean for health? And that was very difficult, but I appreciated it. I respected it, which is very important during COVID. And then I had a series of jobs. I did my PhD at London School of Hygiene and Tropical Medicine. And as part of my field work and part of the PhD dissertation, I went to Cambodia. And I spent about 2 years in Cambodia working on H5N1. 2 years.
For your doctoral work.
On and off, living there for more than a full year at a time, but then going back and forth to finish.
Right.
And everything I learned about outbreak investigation, One Health, was in Cambodia. Incredible people working at Institut Pasteur, Cambodia.
Yes. And Jeremy was there at that time?
Jeremy Farrar was in Vietnam
He was
at the
in
time.
Vietnam at
Yes.
that time. Okay.
It's a very small world of,
Yes.
those of us working in this space. And I basically traipsed around the country in different provinces and looking at how backyard poultry were raised, looking at how birds were traded around the country, and with incredible people at Institut Pasteur Cambodia and the Ministry of Health, flagged people down on the side of the road, middlemen we called them, on their motorbikes with chickens on the back, flagged them down, said, "Where'd you come from?" And we did this big survey of basically mapping how birds moved around the country. And the point was to say, if you want to do surveillance, if you want to detect something early, focus your surveillance in these locations. If you want to catch it, and have the biggest impact, you focus on these locations. Because at the time, and still, and this is relevant in everything we do, you have to use every resource you have efficiently. Human resources, financial resources, and you need to be strategic. So I can't wait to go back to Cambodia. I can't wait. But when I finished my PhD, the 2009 flu pandemic began. And I started a postdoc at Imperial College, and my job was in London. My job was to be the liaison between WHO and the MRC Center, Medical Research Council Center for Outbreak Analysis and Modeling. And it was a group led by Neil Ferguson at Imperial College.
Very famous group.
Yes. And basically, I worked with people at WHO to say, how can a skill set of analytics and mathematical modeling support policy decision and control programs? It was fascinating. Here's the question we want to answer, but here's the data that actually exists to be able to answer, and then you modify. But the flu pandemic began. So Kathy Roth from WHO hired me on a $1 contract because I was paid by Imperial, but I didn't care. I was desperate to work at WHO. I'm unashamed to say so. Absolutely desperate to be at. Because once I learned what WHO was, the World Health Organization, the world's health organization, and particularly in emergency response and outbreak investigation, supporting governments mainly at the worst time, of their existence when there's an outbreak that's raging and you don't know what's going on, to help support them in that and bring that under control, working with a multidisciplinary team from around the world. It was, to me, still is, you can tell, I'm very excited about it. I just thought it was fascinating and I wanted a seat at that table. So having that $1 contract, I didn't care. I just wanted to be part of it. And I was embedded with the Global Influenza Program to support the pandemic response at the time. And I had a small stint at Institut Pasteur in Paris between 2015 and 2017, leading up the Outbreak Investigation Task Force, which was part of the Center for Global Health, essentially working with the network of Pasteur, all of the different institutes, 33 institutes in 26 countries, and supporting local capacity for outbreak investigation, basically setting up a mini GORN, Global Outbreak Alert and Response System, with Pasturians and Ministry of Health officials. I was only there a couple of years because WHO offered me a job in 2017. Well, I applied for a job and I was selected for a job in 2017 as the MERS coronavirus technical lead. Yeah.
And that was when?
It was when there had been so many outbreaks, MERS in Korea and Saudi Arabia. And then, of course, December 2019, we had the cluster of pneumonia of unknown etiology. And the reason I became the health operations lead and the technical lead was because when you have an event, some kind of infectious event, or it could be crisis like a flood or an earthquake, WHO uses what we call the emergency response framework. And we set up an IMST, an incident management support team. And within that structure, you're basically pulled out of your normal departmental lines and you come together on a team, an incident management team. And as one of those roles, I was the health operations lead and became the technical lead. So it was not planned. And I certainly, you said I was a spokesperson. That was never, ever, ever
officially
I wasn't actually, well, no, we actually have spokespeople, incredible comms people that do that.
But you and Dr. Tedros and Mike Ryan would be gathering a couple of times a week.
At one point, it was daily.
And people would be watching you from all over the globe, including us.
Yeah.
So
to do those press conferences.
Yes.
What we thought of it as we just answered a couple questions at the end of the day. It wasn't the main job.
Yes.
The main job was actually consolidating, pulling expertise together, developing strategies, developing evidence-based guidance, supporting countries, to do that. And then at the end of the day, we answered a couple questions. So we didn't realize at the time, I certainly didn't realize at the time that pressure. I certainly didn't realize that level of responsibility. I mean, we're doing our jobs.
Yes.
That's what we were doing. We were doing our jobs. And very grateful to have sat next to Mike and Dr. Tedros and to have been one of those three that were up there for hundreds of press conferences. Hundreds.
Yes, I can imagine.
Yeah.
All duly recorded by your mother.
So my mother put together scrapbooks during COVID, and she's at version 15. And at first it was just pictures of me. I was like, Mom, please stop. I don't want to see any more pictures of myself. But then it was, every press conference we did, every interview we did, and she was recording the case numbers at the time. We were saying things. What were the key things we were saying? And I can't look at them. Like I will, and I will be very grateful for them when I do write that memoir. But I can't look at them yet. It's still a little bit too raw. Yeah.
Well, thank you. Just one personal note. You mentioned Kerkhove and the outbreak in Kerkhove in the mid-90s. There's an air base there, right? And it's down in the corner, the southeast corner of Congo. It's near Angola, not far from Angola.
No.
And I was in Angola in that period when that outbreak was causing all this consternation about cross-border.
Yeah. Ebola outbreaks are still doing that.
And all sorts of investigations. And the border area, Angolan border area, was a very porous. I mean, this was just an open question of what the hell was really going on. But it's funny that coincidence.
It's a small world, this field.
So let's talk about WHO. Thank you for all of that personal story. It's amazing, and I'm sure our listeners are going to love that. Let's talk about WHO because, one of the values of having you here is to really make the case. What is the value proposition for WHO? For an American public listenership, many of whom will be very familiar with WHO's role, but let's assume not. What's the value proposition in your view?
Well, I mean, WHO, the World Health Organization, we do often say the world's health organization. We are the secretariat of 194 member states, and we work across governments, across borders, across every background you can think of to come together to solve the world's biggest health problems. The area in which I work, looking at protecting people, keeping the world safe against pathogens with epidemic and pandemic potential. The ones we know about, like the influenzas, the coronavirus, but also the ones that we anticipate, the novel, the pathogen X, the disease X, which COVID was. And working with governments, working with partners to build the capacities in country to detect something early. And if you detect something early, you can act early. And what's important for Americans, and I think about this a lot lately, what does it mean sitting around the kitchen table? Why do we need a WHO? Right. We live in a completely interconnected world. And the notion that there's going to be some pathogen that's going to emerge in some faraway place and we can protect everybody with borders is a false sense of security. And because we are so interconnected, whatever you detect in one part of the world can be in another in 24 to 48 hours. And so we are working with governments to ensure that there are capacities that exist to be able to act early, but also to scale up and scale down when necessary. There's a whole part of WHO that works on preventative care, looking at primary health care, universal health care, nutrition, vaccines. That's not particularly my area of work, but of course we look at the whole individual and the whole family. And so we are a science-based organization. Our superpower, one of them, is to bring together the world's expertise to solve these problems. And so we don't just sit around I work in Geneva, which is beautiful, and I'm so fortunate, but we have country offices in 150 countries. We have 6 regional offices, and most of WHO actually works in the field alongside governments, supporting governments at their request. We don't infringe on any sovereignty of any country. We actually don't have a lot of power to do a lot, but we bring together the world's expertise to develop that evidence-based guidance. And our partners, agencies like other UN agencies, like Gavi, like Global Fund, UNICEF, they use our evidence-based guidance to implement CSOs. We work with NGOs. That's a core mandate of what we do. But I think one of the critical things right now, especially right now, is with the international health regulations, which is international law that governments have signed up to, member states have signed up to, is to share rapidly information about these type of pathogens that emerge. We do characterization, we do risk assessments, and we share that with all of our member states quickest way possible. It becomes public eventually, but we do this as quickly as possible as we learn, and that's a global good. And so this interconnected world, you sitting around your kitchen table, all of that is happening in the background. You don't need to necessarily know or be scared, but you need to know people like me and the incredible people I work with, and also those that are in country are doing this every single day.
Thank you. There's been various allegations lodged at WHO that it was captured by China during COVID. In the President Trump's most recent executive order issued on Inauguration Day, calling for the withdrawal of U.S. membership within WHO, this was one of the allegations made. There's also allegations that WHO encroaches on U.S. sovereignty. You made reference that that's not true, but say a bit more about these allegations. I think it would be good for you to offer, what's the most effective rebuttal to these charges?
For me, the most effective rebuttal is a dialogue. So we would welcome a dialogue with the administration to talk about all of this.
Yes.
And we're always open to that. I think the suggestion that we were in China's pocket, we were too light on China in the beginning, we certainly did not have enough information from China in the beginning. We've been very vocal about that. Yeah. In fact, my first press conference I ever did was on the 14th of January, 2020. I thought I would never be able to do another one again. I thought I would never be asked to do another one because I talked about what coronaviruses are, what we knew. There were 41 cases at the time. And I said, of course, there's, possible human-to-human transmission, mainly among families. But I did also say that there was the likelihood of super spreading events, which actually was the headline. WHO warns all hospitals to be on alert for super spreading events for this novel coronavirus, which turns out to be a pretty good headline, pretty accurate headline at the time. But I think there was a lot of misrepresentation about how we portrayed China in the beginning, referring to a particular tweet here or there. But the point is we were on TV and vocally talking about this every single day. And more importantly, we were informing our member states every single day, not to the media, but through all of the channels that we have. And we were asking, demanding as much as we can, if WHO can demand anything, more information about what was unfolding, what was happening. And the Director General called an emergency committee, bringing together experts from a roster of experts that we have to discuss the situation. He actually got on a plane.
Right.
He and Mike Ryan got on a plane to go see firsthand what was happening. So there's a lot we could talk about what information did we have when. Did we want information earlier? Absolutely. Did we need information earlier? Absolutely. Do we still have the cooperation from China that we want? No, we don't. So it's a real source of frustration, but it is something that we are actively, engaging on to make sure that that happens again.
We could talk about the whole COVID origins and what happened in this period for a long, long time.
We probably could.
I just want to interject because I want to also touch on the more recent reforms. But Mike Ryan joined me in mid-February at the Munich Security Conference. We had a town hall on the outbreak in 2020.
Okay.
So this was mid-February. This was just a short while before things really closed.
So I was in China at that time.
And this would have been like February 14th or 15th, something like that. And we had the Vice Minister of Foreign Affairs from China there. And it was a broadcast town hall. This was not a closed-door session. And I was moderating this. Mike was there to speak. The Chinese official, Jeremy, was there in his role at Wellcome Trust. And there were others there from the corporate side and elsewhere. But what really struck me was how much of a bind WHO found itself in that moment in time, because it was such a fraught moment. You had to get access. You had to try and figure out what was going on. As we know in retrospect, local provincial officials were scurrying around to protect their own position and not communicating back to Beijing in a clear way. So there were levels of political resistance and cover-up at that time. The Chinese vice minister really played, his message at that time was, don't exaggerate, everything's under control, this is not on a takeoff phase, et cetera, et cetera. And I had just read off, okay, this is all the data that we know as of today, as of mid-February, and let's talk about this because we're off to the races here.
Right.
We haven't shut down yet. And Mike had to be super cautious, right? He had to be very deferential to the Chinese while continuing to sort of say things and remind. But, you were there. He didn't want to see the doors closed. He didn't want to create a diplomatic faux pas. But it was clear that the pressures from the Chinese were intense in that period.
Oh, absolutely.
Very intense.
These outbreaks, there's the public health element, there's a scientific element, but there's the political element as well. And I used to say before COVID, every presentation I gave, that every outbreak investigation I've been on, the science is getting smaller and smaller and the politics is getting bigger and bigger. But in my wildest dreams, I did not expect the politicization of COVID throughout the last 5 years. It's not just with the origins. But I was in China at that time. And at that time, we were seeing data that exists that could bring you to tears. And we were saying, why aren't you putting this out? In the report that we published at the end of February that year, that 2020, we were showing these curves of showing that people tested positive before symptom onset. That was the first time that had ever happened. We didn't understand the implications at the time, of course. And there were a lot of experience with SARS and MERS and infectious period. But yes, the epi curves were going down in many of the cities across the country. They were looking at opening up in a staggering way, but they were also building mega hospitals at the time, right? There was research that would need to be done. There were clinical trials all over the place. And we were saying, put it together so that you have enough patients to do. It is a delicate balance of what we have to do. And there's a long game that we have here. Not to say that people are not wrong to say we needed more information, certainly at the time. And I think to say WHO was one way or another, they say we've been in the pocket of China, but then they also say we're in the pocket of the US. So we kind of can't win. Right. And so that's why we focus on the science. We never issued mandates. We never issued lockdowns. We put out guidance to say, for example, the use of masks and when and where. And you could argue we did it too late. Let's talk about that and how. Maybe not in this podcast, but that's what we should talk about. What did we know when? Did we make the best decisions that we could? Did we communicate it perfectly every time? Definitely not, right? Definitely not. But our goal is to extract the information, use the information that member states provide to warn the world. And it's that agile nature. We were operating in scenarios. So in the beginning, and I was looking at this recently, January 8th, 9th, 10th, I have a document that looks through scenarios. It's a point source. Everything came from the market. It was already circulating, and there were cases within Wuhan as a city of 11 million.
Yes.
It was in Hubei. It was across China, or it was, it was circulating globally. But you have to prepare for each one of those scenarios. So our guidance, we issued a package of guidance on January 9th through the 12th. This was less than 2 weeks. We published the first PCR protocol with Charity University, Christian Drosten's group, that had been validated by a number of labs around the world, in Hong Kong, in the US, in London, in the Netherlands, to actually start producing tests.
Yes.
And we were shipping those tests to Africa by the end of January, early February. Many countries in Africa were testing before some high-income countries. That's the job. That's the role. And I think, when people want to criticize us, that's fine. Constructive criticism, we are very critical ourselves. We want to be better. The people that work at WHO are civil servants. We don't represent our governments. I became the American infectious disease epidemiologist, but we serve others. And I think right now, with what's happening in global health, which is so heartbreaking to me, is the people that work in this area, this field, are doing it for others, in service of others. And for us at WHO, our only job is to keep people safe. There's no other motivation than that. So what we're trying to do now, and with the pandemic accord and with building capacities and having partnerships, is how do we do this better the next time? There will be a next time. And it could happen in China, but it could also happen here in the United States.
Now I'm going to shift here in the interest of time. Very significant reforms have been introduced at WHO recently amidst a really serious budgetary set of pressures. And these have been detailed. They're not every last detail's been disclosed yet, but many of the most important details have been announced. And this plan now goes to the World Health Assembly
That's right.
starting next week.
Mm-hmm.
Just give us a quick summary. This is a very significant set of reform measures.
It is, but I do want to highlight that reforms for WHO actually started when Dr. Tedros took office in 2017. It isn't a result of the executive order that came on January this year. And it's something I think is really important for the listener to know because we are a learning organization. We went through the 2014, 2015 Ebola outbreak in West Africa, and a lot of reforms happened there. The health emergencies program started then, but there's been a lot of reforms that have happened over time. What you're referring to right now is WHO is in the process of a reorganization, essentially. And we have to be much more efficient with less people and less finances to serve the world. And as a member state organization, the member states, articulate what they want us to do. And that happens at the Health Assembly every year. That's happening next week. So right now, we're moving from 11 divisions to 4.
Yes.
And within the health emergencies program, we actually started this realignment 18 months ago, 20 months ago. We went from 11 departments to 6, and now we're actually going down to 5. So we're streamlining.
Your senior executive team is going from 14 to 7.
Yes.
The departments.
And that was announced very recently. And yes, and the departments are shrinking. So we're going from something like 70 plus directors to 30 plus directors. Yes. And we're going to lose around 25% of staff or so. The exact number will depend on who goes and how, but we have to prioritize what we do and really focus on the core mandate of what WHO does, the norms and standards, what others don't do. Emergency preparedness and response is one of those essential functions. But yeah, it's a big shift. It's really hard. I have to say, as a manager, I'm acting director. COVID stress was one thing. This is totally different. I don't handle it very well.
Yeah.
And we're letting really good people go. So it's heartbreak, but it is the reality of what we're in. The funding coming to WHO. And I should point out that our operating budget is less than one hospital in one high-income country.
So your budget, you operate on a 2-year budget.
Mm-hmm.
Your current 2-year budget is $6.8 billion. The budget that's going to be tabled next week at the World Health Assembly for the next 2-year period is 4.2.
Correct.
So that's a dramatic
It's a dramatic
shift.
jump, which means some work has to stop.
And so you're really going to have to make some hard choices. And moving the number of divisions down, it's really kind of making some tough choices around what are the core functions.
That's right. And I think in our area of work around the health emergencies program, it makes sense. Our narrative makes sense. So I deal with threat management. And so I'm looking at the biological risks, the influenzas, the coronaviruses, but also the arboviruses, the viral hemorrhagic fevers, the Ebolas, the Marburgs, the CCHFs, the bacteria. We deal with cholera. There's a massive cholera outbreak, multi-country outbreak that's completely preventable. We also look at laboratory biosafety, biosecurity, ensuring that labs, the capacity for labs has expanded dramatically since COVID or through COVID, and looking at medical countermeasures. But the fiscal space that we operate in changed since the crisis of COVID, obviously, and it couldn't be maintained as it was, and it was shifting, and governments were putting money into Ukraine and into Gaza and into humanitarian crises, rightly so. But now many of the governments, their ODA, their funding that they're providing from their budgets is going from health to defense. And so it's shrinking even further. So we have to optimize every dollar that comes through. We're going to have to do less, but there are critical areas of work that cannot stop. And surveillance is not going to stop.
Last issue for this conversation. What does it mean? What happens when the U.S. withdraws not just its funding, which was the lead funder, and that amounted to over $600 million a year.
In voluntary contribution and assessed contribution, yes.
And sometimes it would be higher. And we withdrew over 30 experts that had been seconded to various places within WHO. And then we ceased our cooperation, with a few exceptions, on pressing and important and complicated technical and scientific issues. What does this mean when the U.S. walks away from the table in these different ways?
I actually really appreciate how you asked that, because most people focus on the money. And of course, that's a significant gap.
Yeah.
But what is more critical right now is that lack of technical exchange. And that never happened before. Even in the first Trump administration, when they signaled their intent to withdraw, the communication continued. Scientists work with scientists. And since late January, conversations, formal, informal, through our expert networks in important meetings, U.S. government officials have been instructed not to talk to us, not to work with us.
Yeah.
And when you don't have American voices, there's incredible expertise here. There's incredible expertise from all over the world. And we bring together, just as we're not in the pocket of China, we're also not in the pocket of the US. We look at the diversity of voices, but if American expertise is not at the table, there's a gap. And that loss of voice is significant. It will be filled by others, and it is being filled by others. I should say that the US is still reporting cases through the International Health Regulation of cases like H5N1, but there is significant gaps. If we talk about avian influenza in terms of the surveillance that's happening here, the reporting through mechanisms like GISRIS, the Global Influenza Surveillance and Response System, that's stopped. So we still need access and information about what is circulating here, just as Americans would expect to have that information coming out of China or coming out of Angola or coming out of Canada. And so that loss of technical exchange hurts Americans. Not being at the table with WHO, not being able to have we still communicate with
puts us
the
at
US.
risk.
It puts you at risk.
Yeah.
And so the US has signaled its intent to withdraw. You're still a full member state until next year. And we will continue to reach out. We have not stopped reaching out to our colleagues. They can't report back. And they do have some exceptions to join some meetings. Sometimes they can speak, sometimes they can't. This is what I really hope is lifted. It keeps America. Restore that link immediately, because that keeps Americans sitting around that kitchen table saying, why is this important? Much safer than otherwise.
Thank you. We ask all of our guests to close by just telling us what gives you the greatest hope and optimism in this period.
People, brilliant minds that want to help. I think I'm just inspired by the people I work with. They're an exceptional group of individuals in Geneva, but also around the world. And I'm inspired by them. They get me out of bed. There are a lot of days I have not wanted to get out of bed. I'm not going to lie. But we have a job to do. And when people say, like, how is this? We know exactly what to do. We are not distracted by what's happening, in the world. In fact, I think that makes us even more focused to do more with less.
Thank you. Thank you so much for your leadership and your commitment and for making time for us today.
Thank you for having me.
And good luck tomorrow in your commencement address.
Thank you. Thanks very much.
Thank you for listening to The Common Health. If you enjoyed this podcast, please give us a follow and leave a review. To learn more about the CSIS Bipartisan Alliance for Global Health Security or listen to other CSIS podcasts, please visit csis.org.